Hi, it's Bree Smith, SN, here to help you succeed in nursing school and on the NCLEX.
In this video, we are covering hematological pharmacology. We are covering a wide variety of drugs, so check the chapters and timestamps to help you find specific ones you are wanting to focus on. Let's begin. We'll begin by identifying some forms of anemia, as well as the pharmacologic interventions indicated to treat them. For the treatment of iron deficiency anemia, iron supplementation may be indicated. Ferrous sulfate is commonly taken PO form, while iron dextran may be given IV. The therapeutic effect of iron supplementation is to facilitate the production of hemoglobin in the blood. So patients' HGB, HCT, and RBC counts may increase on this medication. There are some side effects to prepare the patient for. The most commonly reported is GI distress, such as constipation and black or dark stools. The patient should be educated to increase fiber, fluids, and activity to counter constipation, and to not be distressed if stools appear dark. Oral suspensions may contribute to a metallic taste and teeth staining, so use of a straw and mouthwash afterwards is advised. In the rare instance that iron toxicity occurs, gastric lavage or bowel irrigation may be required. The antidote, deferoxamine, may also be given, which acts to bind to freely circulating iron and promote its excretion through urination. When giving iron supplementation, there are several administration practices to consider. For the PO form, vitamin C may increase absorption. PO form of the medication should be taken on an empty stomach or with vitamin C, but other substances should be avoided at that time. If multiple doses are required to achieve normal serum levels, they should be taken across the day rather than all at once in order to maximize potential absorption and efficacy. Another administration consideration with this medication is that if given via IM shot, make sure to use the Z-Track method to prevent local site discoloration. Vitamin B12 deficiency anemia, also known as pernicious anemia, also requires therapeutic interventions if dietary modifications to increase B12 are not effective. B12 is found in animal protein sources, so patients at risk of this deficiency include vegan patients. Also at risk are those who lack intrinsic factor, meaning that consumed B12 cannot be absorbed. B12 cyanocobalamin may be given to treat deficiency. Side and adverse effects to watch for include diarrhea and hypokalemia, the latter being a consequence of potassium expenditure that occurs during erythropoiesis. At-risk patients should be assessed for potential muscle weaknesses, cramping, and the presence of U waves on ECGs, which could indicate hypokalemia. The final form of anemia we will cover is folic acid deficiency anemia, treated with folic acid supplementation. Patients at risk include those with malabsorption conditions, as well as pregnant patients. It is important, especially for females of childbearing potential, to have adequate intake of folic acid in order to decrease the risk of neural tube defects in the fetus. Administration considerations are that at maintenance dose, the client should have an intake of 400 micrograms of folic acid daily. For patients intending to become pregnant or who are at risk for having a fetus with a neural tube defect, 4,000 micrograms is recommended. Usually, folate is given PO route, but if given IV, such as through a banana bag, the patient may experience non-concerning flushing and warmth if the infusion is too rapid. Hemophilia is an X-linked recessive bleeding disorder, where an inadequate clotting factors can lead to prolonged bleeding times in these patients. Factor replacement may be achieved from exogenous administration of factor VIII for type A hemophilia, while factor IX replacement is indicated for type B hemophilia. To remember this, consider that 8 contains an A sound. Therapeutic effects should reflect that the APTT is now within expected range, with bleeding times less prolonged in these patients. Adverse effects of factor replacement may include allergic reactions and anaphylaxis. Patients with a history of reactions or the presence of a mild reaction may be treated with antihistamines, but the presence of anaphylaxis should indicate the use of epinephrine. Another important note here is that using most NSAIDs while on factor replacement can contribute to clot promotion. Only COX-2 inhibitors, such as celecoxib, should be used for analgesia and anti-inflammation in these patients. Remember this by thinking of a celebrity with hemophilia who only will take celecoxib. Another medication we'll cover is one we previously mentioned in the endocrine video, that being desmopressin. So what is exogenous antidiuretic hormone doing here? Well, this medication may actually be indicated for short-term management of hemophilia A as it promotes clotting factor release, such as by increasing von Willebrand factor in the serum. It may be indicated to be given prior to and throughout surgery or trauma in order to promote therapeutic clotting and prevention of further complications. Our adverse effects reflect reflect those already covered in the endocrine video, including potential for fluid retention and relative hyponatremia as a consequence of the vasopressor effects. Serum sodium levels should be monitored, with the patient assessed for indications of hyponatremia, such as changes in the level of consciousness, cerebral edema, confusion, and seizures. On to medications used in the prevention and treatment of thromboembolic events. This is a high-yield category of medications, common in clinical practice as well as in the NCLEX. Before we dive into more specific medications, let's review some general considerations for all of these. To start, the priority is to assess for complications of bleeding following the administration of these medications. Too much of a good thing can be a deadly thing in this case. Also important is to incorporate patient education that emphasizes avoiding herbal supplements that can increase bleeding risk. These are your 3 Gs: garlic, ginseng, and ginkgo biloba. To remember this, put a twist on the Girls' Generation song G. G, 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 you're bleeding, bleeding. Yikes. Let's never sing on this channel again. With those considerations in mind, let's dive into the medications. The first type of anticoagulants we will cover are heparins, including low-weight molecular heparin such as enoxaparin. These medications act to interfere with the clotting process, preventing the future formation and worsening of clotting. Heparin is utilized for more acute circumstances, given in units and through IV administration only. Often it is given as a bolus dose and then as a continuous infusion, titrated to effect. On the other hand, enoxaparin is a subcutaneous injection given in the abdominal wall and indicated for outpatient management on a short-term basis. To evaluate the efficacy of heparins, we look at the activated partial thromboplastin time, or APTT. Normal APTT is around 30 to 40 seconds, but is generally demonstrating effect on these patients if it is 1.5 to 2.5 times that reference range. Nursing priorities here include keeping an eye on that APTT, holding the dose and clarifying with the provider if it becomes so prolonged that the patient is now at risk for bleeding. Limit unnecessary invasive procedures and monitor these sites as well as mucous membranes for bleeding. The antidote for heparin overdose is protamine sulfate, and this medication may need to be given if the patient begins to exhibit indications of hemorrhage. Another form of anticoagulant which acts to inhibit the synthesis of clotting factors is warfarin. It achieves this by interfering with the physiological role that vitamin K plays by producing clotting factors. With this medication, we will utilize PT and INR in order to evaluate the efficacy of the medication in treatment. To remember this, I think that a soldier has to go through PT and international warfare. A therapeutic INR is around 2 to 3 for these patients, and dosage may be increased or decreased to maintain this level. Like the aforementioned anticoagulants, we are concerned with risk for hemorrhage here. Monitor for indications of bleeding, such as decreased HGB and HCT, tachycardia and hypotension, bleeding at open sites, and tarry stools. Vitamin K may be administered as an antidote for warfarin overdose. Patient education should include teaching about vitamin K intake. NCLEX review resources state that patients should maintain a consistent range of vitamin K intake, neither excessively limiting nor consuming this nutrient. Vitamin K can be found in dark leafy greens such as spinach, kale, and broccoli, as well as in eggs and blueberries. Patient education may also prepare the patient for the delayed therapeutic effects of warfarin. As a consequence, the patient may be initially started on heparin and warfarin concurrently, with the former discontinued as warfarin achieves therapeutic effect. It is especially important to teach the patient how to recognize and report indications of bleeding at this time, as combining anticoagulants contributes to increased risk of complications. Clopidogrel is an antiplatelet, which inhibits platelet aggregation in the body when taken as indicated. Interfering with normal platelet function may contribute to complications such as bleeding as well as TTP, thrombotic thrombocytopenic purpura. TTP can lead to the destruction of blood cells that in turn impairs perfusion and contributes to ischemia and necrosis of tissues and organs. Monitor the patient for petechiae and purpura that can clue you into the presence of this internal bleeding. If TTP occurs, anticipate plasma replacement therapy. Prior to any expected surgeries, this medication should be stopped for at least 7 to 10 days to reduce risk for hemorrhage during the operation. Our final medication here is one of our most potent, the thrombolytic alteplase, which breaks down existing clots and prevents the formation of future clots. Alteplase is a high-risk medication and a major risk for severe hemorrhage. However, it can be life-saving if given within the proper window of administration to treat ischemic strokes and heart attacks. Let's focus on proper administration. The IV infusion of alteplase should be given within 3 hours of recognition of signs of stroke and within 2 hours hours of recognition of MI. The medication is weight-based, and patients must not fit the criteria of any absolute contraindications. What are those absolute contraindications? They include any recent intracranial hemorrhage, or the presence of any active bleeding, the presence of structural abnormalities or trauma of the CNS, an ischemic stroke within the previous 3 months, uncontrolled and severe hypertension, and any significant craniofacial trauma within the previous 3 months. If the patient meets any of this criteria, administration of this thrombolytic poses too significant of a risk. Prior to administration, a baseline neurocheck should be performed to monitor for any changes during therapy that could indicate intracranial hemorrhage or shock. The patient should be monitored closely, and any invasive procedures should be limited. Pressure needs to be put on puncture sites from anywhere of 20 to 30 minutes to allow enough time for clotting to occur. Our final class here addresses medications which promote various aspects of hematopoiesis, or the creation of new blood cells. Bone marrow suppression as a consequence of disease processes or medications may require the patient to be on some of these medications. The first is epoetin alpha, which is exogenous erythropoietic growth factor. This stimulates erythrocyte formation in bone marrow, allowing for the production of increased red blood cells. Patients with anemia, immunosuppression, or chronic renal failure may benefit from this medication. More red blood cells can increase the viscosity of the blood, thereby increasing the risk of hypertension and clotting. Therefore, monitor the HGB and coagulation studies of these patients and hold the dose if above acceptable range. Filgrastim is a leukopoietic growth factor, which stimulates the formation of leukocytes such as neutrophils. This makes it valuable in the treatment of bone marrow transplants and neutropenic patients. Adverse effects relate to increased white blood cells, where patients may develop bone pain, fever, and splenomegaly, as more white blood cells are sequestered in this organ. Fever should be controlled with antipyretics such as acetaminophen, and bone pain may require the administration of round-the-clock opioid analgesia. The final medication we will mention is oprelvecin, involved in thrombopoiesis, or the formation of platelets. This is achieved as stem cell production in bone marrow is stimulated, increasing mature blood cells of all types. This medication may be used to treat patients with thrombocytopenia, as well as during transplant protocol to reduce the need for replacement. Increased platelets can contribute to increased viscosity of the blood, thereby contributing to hypertension and endovascular damages, which may lead to cardiac dysrhythmias. Monitor the patient for dysrhythmias and profound edema and dyspnea. This may indicate that the medication should be discontinued for these patients. Thank you for watching this quick review of hematologic drugs. While this is far from a comprehensive breakdown, the most commonly emphasized points on the NCLEX and in clinical practice are covered here. Please make sure to utilize your assigned textbooks and modules in addition to this review.
Remember to keep studying and keep working hard.